Welcome to the Deep Dive, your shortcut to being the most informed person in the room. Today, we're exploring one of medicine's most evocative and honestly surprising conditions.
It's one that literally proves that severe emotional or physical stress can, well, physically break your heart.
We are diving into Takotsubo cardiomyopathy, or TCM.
It really is an incredible story about the mind-body connection. I mean, it shows how raw emotion can translate directly into acute physical cardiac failure.
So what is it at its core?
At its core, Takotsubo is an acute but, and this is the crucial part, reversible systolic dysfunction of the left ventricle.
The main pumping chamber of the heart.
That's the one, and it's caused not by a clog, but by a sudden, just intense surge of stress hormones.
And the name is just amazing, Takotsubo. It doesn't sound like a medical term at all. It sounds like something out of a deep-sea documentary.
It's purely descriptive. A kakotsubo is it's a type of pot that Japanese fishermen use to trap octopuses.
Okay.
These pots have a really wide, round bottom and then a very narrow neck. And when someone has this cardiomyopathy, the base of their left ventricle keeps squeezing hard, but the apex, the bottom tip, it just balloons out. It stops moving.
So on an ultrasound or an angiogram, the heart takes on that exact, unique shape of the octopus trap.
Precisely. That apical ballooning is the visual hallmark.
So our mission for this deep dive is pretty clear then.
I think so. For you, the listener, you need to walk away understanding the distinct difference between this condition and a traditional heart attack, because these patients, they come in with crushing chest pain, classic ECG changes.
Elevated biomarkers.
Everything. They look, smell, and sound exactly like someone having a massive heart attack, what we call acute coronary syndrome.
But the underlying mechanism is completely different, and that's the key. If the heart muscle is stunned, not, killed by a blockage, the treatment path changes dramatically.
Exactly. We're separating a true vascular catastrophe from a stress-induced temporary paralysis.
Which is a critical distinction to make in the emergency department.
It absolutely is. While TCM only accounts for, say, 1 to 2% of patients who are first suspected of having a heart attack, missing it or mismanaging it, that can be catastrophic, especially with some of the treatment nuances we'll get into.
Okay, so let's start at the beginning. The trigger. What kind of stress are we talking about that can just instantly cause acute heart failure?
It's often categorized into two massive buckets. The first one is the intuitive one, emotional stressors.
Right.
This is things like acute grief, intense fear, the shock of violence, or, the trauma of losing a loved one. This is where that nickname, broken heart syndrome, really came from.
It's that kind of instantaneous, profound emotional shock that makes you physically clutch your chest.
It is, but what I find so fascinating is the rare variant the sources bring up, happy heart syndrome.
Right. I saw that. It's completely counterintuitive.
It's a powerful insight into the pathology. It proves that the heart doesn't care about the emotional polarity. It doesn't register if the news is good or bad.
It only registers the sheer, overwhelming magnitude of the sympathetic nervous system kicking in.
The magnitude and the suddenness. So, winning the lottery, a surprise marriage proposal, getting some incredible life-altering news that can cause the exact same adrenaline flood as getting mugged.
The heart is just reacting to the shock.
Exactly. Now, the second category, and this is often more common, especially in an ICU setting, is physical stressors.
So things like an acute illness.
Yes, a severe infection or sepsis, major non-cardiac surgery, a stroke, internal bleeding, even a severe asthma attack. The common denominator is a systemic, sudden physiological threat.
And yet, in about a third of all cases, no trigger is ever found.
Which is a real clinical challenge.
Let's talk about the demographic,
Yeah.
because this is probably the single most defining characteristic of Takotsubo. If stress is universal, why are the vast majority of patients postmenopausal women?
We are talking about 90% of cases. 90. In women, typically between 50 and 75 years old. This is not random. It really comes down to a fundamental physiological shift that happens after menopause.
The estrogen factor. What was estrogen doing that was so protective?
Before menopause, estrogen acts like a protective shield for the whole cardiovascular system. It does three critical jobs. First, It encourages vasodilation. It keeps blood vessels open by increasing nitric oxide.
Okay.
Second, it modulates or sort of dampens the body's response to adrenergic signaling, so how the heart responds to adrenaline. And third, it protects the tiny vessels from microvascular dysfunction.
So the loss of estrogen isn't just a hormonal change. It's like removing a critical buffer against stress.
It's the single biggest change that makes the heart vulnerable. Once that estrogen shield is gone, the heart muscle, the myocardium, becomes so much more sensitive to the toxic effects of catecholamine surge. The receptors are just wide open and unprotected when that adrenaline tsunami hits.
And we also see higher rates of anxiety and depression in these patients, which suggests they might already be running a higher baseline of sympathetic activity to begin with.
That's a strong hypothesis, yes.
Okay, let's get into the mechanism, the adrenaline tsunami. If the arteries are clear, what exactly is happening to the muscle cells that makes the apex just seize up and balloon out?
We're talking about levels of stress hormones that can be 2 to 3 times higher than what you'd see in a typical severe heart attack. This sudden surge just completely overrides the body's normal regulatory systems. It essentially poisons the muscle cells.
And that leads to what the sources call myocardial stunning.
Stunning is the perfect word for it. It's a temporary paralysis, not permanent death.
How does that poisoning actually work at the cellular level?
The main mechanism is direct toxicity, and it's caused by intracellular calcium overload. Catecholamines flood the cell, and they drive a huge amount of calcium ions into the heart muscle cells.
But wait, isn't calcium what makes the muscle contract? Why is too much a bad thing?
That's the paradox. You're right. Normally, calcium sparks contraction. But when you get this sudden, enormous overload, it disrupts the whole electrical balance. It impairs both contraction and relaxation. Think of it like a circuit board getting hit with too much voltage. It just temporarily fries the system. The muscle loses its ability to coordinate a proper squeeze.
That explains the stunning, the temporary dysfunction. But it still doesn't answer the big mystery. Why the octopus trap shape? Why does the base contract too hard while the apex freezes? Shouldn't the whole heart shut down if adrenaline is everywhere?
And that brings us to the concept of regional sensitivity, which is so crucial here. Studies have shown that the apex of the left ventricle, that bottom tip, it has a much higher concentration of beta-adrenergic receptors compared to the base.
So the apex is the receptor hotspot. It's like a giant sponge for that toxic surge.
That's a great way to put it. When the adrenaline tsunami hits, the apex just gets completely overwhelmed. It absorbs the bulk of the toxic load, and that causes it to shut down. We call that ekinesis.
And the base?
The base has fewer receptors, so it reacts differently. It often hypercontracts, it squeezes too hard, trying to compensate for the failing apex. That differential sensitivity is what creates the unique ballooning shape.
That's a phenomenal insight. And the sources also mention microvascular spasm and even structural disruption to the muscle cells.
Correct. So the end result of this whole process, the calcium overload, the stunning, the regional shutdown, is acute transient heart failure with a reduced ejection fraction, HFrEF. And the key takeaway here is that it's a cardiomyopathy, a primary muscle disorder, not an infarction from a blocked vessel.
Which brings us to the clinical dissection. The patient comes in, post-stressor, with crushing chest pain, shortness of breath. The team is running at full speed because this looks exactly like a massive heart attack.
And they have to. You absolutely must assume it's a heart attack until you prove otherwise. The initial tests often just confirm that suspicion.
The ECG, for example.
The ECG frequently shows dramatic ST segment elevation. I mean, the classic signature of a serious blockage, especially in the precordial leads.
And the blood tests, the troponin, that also shows muscle damage.
Yes, troponin, our gold standard biomarker for heart injury, is elevated. But here is the critical clue, the diagnostic nugget that makes us pause and reconsider. It's the troponin mismatch.
Walk us through that mismatch. What are the two pieces of data that don't add up?
Okay, so the ECG changes and the patient's severe symptoms, they suggest massive, life-threatening muscle death, a huge area of necrosis. But the troponin levels, while they are elevated, are disproportionately mild. They're low relative to what the EKG is screaming at you.
So the electricity and the symptoms are suggesting total annihilation, but the biomarker is suggesting just minor damage. Why?
It goes right back to the mechanism. Stunning versus death. A traditional heart attack, an MI, involves ischemia and then necrosis. The muscle permanently dies because a vessel is blocked, and that death releases huge amounts of troponin.
But in Takotsubo, the muscle is just stunned.
Primarily stunned. temporarily paralyzed, but not permanently killed. So you get a slight troponin elevation from some of that patchy temporary injury, maybe some microvascular spasms, but not the widespread necrosis of a true infarction.
And that mismatch is the first big red flag.
The first major one. But again, suspicion isn't proof. The patient is unstable, you can't wait. You have to manage this as an acute coronary syndrome until you definitively rule out a blockage.
Which brings us to the moment of truth. To move beyond suspicion and confirm Takotsubo, you need definitive imaging. What's the first mandatory step?
Coronary angiography. This is the ultimate differentiator. You rush the patient to the cath lab, you inject the dye into the coronary arteries, and they're wide open.
No obstructive coronary artery disease.
No blocked vessel, no ruptured plaque, nothing.
This is that powerful analogy. Broken heart, open arteries. The plumbing is clean, but the pump itself is broken.
And that result immediately shifts the diagnosis away from MI and toward a cardiomyopathy. Once we know the arteries are clear, we move to visualizing the muscle itself, usually with an echocardiogram.
And that gives you the visual proof.
The pathognomonic proof. The echo confirms that characteristic apical ballooning, the non-moving apex, combined with that hypercontractile base. And critically, that wall motion abnormality, it doesn't conform to the territory of a single coronary artery.
Right, which is how you know it wasn't a localized blockage. An MI always follows the territory of the artery that's blocked.
Exactly. TCM is regional, but it crosses those vascular boundaries because the damage is driven by a systemic hormone surge, not a local clot.
The sources mention one last step, cardiac MRI. If you have a clean angiogram and the octopus shape on the echo, why do you need the MRI?
The MRI is sort of the final arbiter. It confirms the reversibility and helps rule out other things that can look similar, like myocarditis. And the key finding on MRI for Takotsubo is that while you see myocardial edema swelling, which indicates injury, there is absolutely no late gadolinium enhancement, no LGE.
And LGE is the marker for a permanent scar, for necrosis.
Exactly. Its absence is the final proof that the injury is transient, stunning, not permanent, irreversible death. So, to summarize the differentiation for you, an MI is acute, it follows a single vessel, and causes a prominent scar with LGE. Dilated cardiomyopathy is chronic and global, but Takotsubo is acute, regional to the apex, stress-triggered, and completely reversible.
And given that dramatic onset, the really good news here is that the prognosis is overwhelmingly positive. It's scary, but is usually not permanent.
That reversibility is one of the most amazing parts of the condition. The left ventricular function typically recovers completely. The heart goes back to its normal strength and shape within usually 4 to 8 weeks, sometimes a bit longer.
So what does that initial acute management look like? The patient is in acute heart failure. You have to support the pump while it recovers from that adrenaline assault.
Management is pretty much standard supportive care for HFrEF. We use medications like ACE inhibitors or ARBs to help with healthy LV remodeling and long-term recovery.
Diuretics for congestion.
Diuretics are essential if there's fluid backup. And we also use beta blockers. They're critical to blunt the effect of any residual catecholamines, and they might help reduce the risk of it happening again.
Now, you mentioned a critical trap to avoid. Something about left ventricular outflow tract obstruction.
This is extremely high yield for clinicians. Because the base of the heart is squeezing so forcefully it's hypercontractile, it can physically narrow the exit route for blood leaving the ventricle.
It creates a blockage.
A dynamic obstruction, we call it LVOT obstruction. It's rare, but it's dangerous. Because if the heart is failing and the LVOT is obstructed, the natural instinct is to give inotropes to make the heart squeeze harder.
Which would be catastrophic here.
Absolutely. A drug like dobutamine would make the base squeeze even harder, worsening the obstruction and causing the patient to collapse. If they're hypotensive, you need something like a pure alpha agonist, maybe phenylephrine, which raises blood pressure without making the heart contract more forcefully.
That is a life-saving distinction. So beyond pump failure, what are the big complications to watch for in those first 24 to 48 hours?
The main dangers are arrhythmias, especially ventricular tachycardia, which is often triggered by the QT prolongation we see on the ECG. But maybe the most serious complication we monitor for is a left ventricular thrombus.
A blood clot forming inside the heart.
Exactly, because the apex is stunned, it isn't moving, so blood just sits there. It's stagnant. And stagnant blood clots, if that clot breaks off, it can go straight to the brain and cause a devastating stroke.
So aggressive anticoagulation is key.
It's essential, at least until that apical movement returns.
So the whole pathway is clear now. An acute stressor causes a massive adrenaline spike, which poisons the heart muscle, especially the receptor-dense apex. The resulting stunning mimics a huge heart attack, but the proof is in the clean arteries and that unique octopus shape.
And that proof gives us the confidence to treat the transient muscle disorder appropriately, which, remarkably, often leads to a full recovery. This condition really shows the heart isn't just a simple pump, it's a profound chemical reactor, and it's highly sensitive to the chaos of the sympathetic nervous system.
It's just amazing that something as ephemeral as shock or grief can cause such a distinct physical injury, and yet the heart can heal itself completely in a matter of weeks.
Yeah,
It can just reset.
it can. And it raises a powerful final thought for you to explore. Since the sources establish that Takotsubo, an injury from an overwhelming acute chemical spike, is almost always reversible, what does that tell us about the heart's inherent potential for resilience, for regeneration, especially when faced with other forms of stress-induced injury, maybe those that are less acute but more chronic?
A great question to take away as you consider the sheer power of stress hormones.
Yeah.
Thank you for joining us for this deep dive into the heart, the octopus trap, and the adrenaline surge.